Well, thanks very much for attending this session during lunch, and I hope that these three talks have some common themes. And I'm going to build on some of the material that Andre just presented and go into a little bit more detail on the non-ultrasound piece of that. So I'm going to talk about cerebral blood flow monitoring and blood pressure management and autoregulation. I don't have any disclosures as it pertains to this particular talk. And essentially my objective, and what I want to accomplish over the next 15 to 20 minutes, is I really just want to talk about the relevant cerebral physiology to better understand those factors that can influence cerebral blood flow during cardiac surgery. Now, we already know that there's a number of different ways that we can sort of regulate our cerebral blood flow during cardiac surgery. I mean, we know about cerebral metabolism and how there's this link between blood flow and metabolism, so-called metabolic autoregulation. We also know that there's blood pressure autoregulation as well in the brain. Some of the other factors that have an influence on cerebral blood flow include carbon dioxide and oxygen. And also, we also know that there's some neural mechanisms that are involved in brain blood flow as well. But really, I'm going to spend most of my time talking about the blood pressure component as well as the oxygen and carbon dioxide components. Well, measuring cerebral blood flow, we already know that there's a number of different parameters that are available to us to do this. Certainly, using CT scanning with xenon cerebral blood flow gives us some very pretty pictures, as well as PET scanning. We know that MRI can give us some very nice pictures of the blood flow within the brain itself, but none of these are really available to us intraoperatively, of course. We've seen already that transcranial Doppler can provide both insights into the blood flow velocity in the vessels that are being insunated, as well as giving us some idea of what some of the high-intensity signals representative of emboli are. So that can give us some idea of what the perfusion and blood flow is to the brain. But the other thing with transcranial Doppler, and certainly with some of the early techniques that were being used, is this is a study that we did quite a number of years ago, and one of the downfalls I find to transcranial Doppler is that there are a number of patients where it's difficult to get a reliable signal. Now, I think that's changing with some of the technologies that are out, that are available now, but I think it was really one of the major limitations. And it's really why we looked for alternate means to look at cerebral perfusion. And obviously, one of the means that we use now are the range of cerebral oximetry devices which are available on the market. This is a slide which is a few years old now. These are the 6 devices that were approved then. It's now 8 devices that are available to us. And we know that these work on the same sort of principle. There's some very distinct similarities between these devices as well as some differences. But essentially, these devices are allowing us to understand what the saturation of the hemoglobin that it's residing in the brain, both in the arterial side of the circulation as well as the venous side of circulation. And there are means to indirectly understand perfusion to the brain. So this is where I'm going to take the pieces of the algorithm that Dr. Deneau didn't go to in detail. These are some of the ones that are more directly related to the blood pressure, oxygen and carbon dioxide components. So what interventions will improve cerebral saturation? Some of this will pertain to cerebral blood flow. Others will pertain just to the saturation independent of blood flow. So this is the algorithm that we've already seen. I'm going to break down this into some of the components that I want to focus on, and I'll skip over the ones that Dr. Deneau has already covered. So I think verifying the position of the head of the patient is actually very, very important. And let me give you an example of why that is important. Certainly jugular venous compression, both globally by having some surgical trespass is possible, but sometimes we can get into a situation in what we're doing at the head of the table where it can also compromise the venous outflow from the brain. And this is here's an ultrasound of a patient who is having their internal jugular vein cannulated in a very routine fashion preoperatively. We can see on the left side we've got a very large internal jugular vein, the carotid artery is here. But notice on the right side we have this rather atretic internal jugular vein. So you can imagine when you're actually putting your central line in and you're turning the head towards the left and you're occluding the only major passage for the venous outflow from the brain, you could have some significant changes in cerebral saturation. So keeping that head in a very neutral position, I think, is very important. We know that a certain percentage of our patients have an incomplete circle of Willis. In fact, 15% have either an absence of that anterior or posterior communicating artery, which is very important when one is trying to interpret some of these signals. Certainly when there's concomitant carotid stenosis, there's also some impairment in blood flow to the brain. And I think one of the other things which we fail to recognize sometimes in these patients, and again, in that verifying of a neutral position of the patient's head, is that a lot of patients have abnormal vertebrobasilar blood flow to the brain. And in fact, this is a very interesting syndrome which is more well known in the neurology literature, which is known as Bowhunter syndrome. And essentially what it is rotational occlusion of the vertebral body at the level of C2. So again, if the head is rotated to the extreme left or right, you can actually occlude the vertebral artery, even in normal patients. Obviously, those that have vertebral basilar insufficiency and you have the head in a very extended position, you can certainly compromise that as well. So that neutral head position, very important. We also heard about inspecting for surgical problems and looking at dissection with the TE, but really I want to spend the majority of my time looking at the other traditional determinants of understanding cerebral blood flow. And this is a graphic which has been reproduced innumerable times from the work at Mayo Clinic by Dr. Mitchenfelder, which he published quite a number of years ago. And essentially what it was outlining was the pressure autoregulation within the brain here, as well as the influences of the partial pressure of oxygen and the partial pressure of carbon dioxide. So let's go into those in a little bit more detail. Well, we know autoregulation is this intrinsic ability of the brain to maintain a normal blood flow despite large variations in blood pressure. And it's really the intrinsic function of the cerebral vessels that as the blood pressure continues to increase, we have this progressive sort of narrowing or vasoconstriction of the cerebral vessels so that we can maintain a normal blood pressure right across a range, or normal blood flow across a range of blood pressures. We also know that once we get beyond this hypertension causes this forced dilatation of the cerebral vessels. And of course, when we lose our autoregulation at the lower end of the threshold here, we have a collapse of some of those vessels as well. So there's a couple things, excuse me, that I'd like to highlight, what we understand and maybe what we don't understand about cerebral blood flow. Well, one of the things that we see from this particular graphic is that although we often talk about this as a plateau, it probably actually has a slightly positive slope to this. And this was actually demonstrated in some work from my former colleagues at Duke University more than 20 years ago, where here we have blood pressures in a fairly conventional range during bypass, mean arterial pressures of 50 to 75, and we can see there's a small increase in cerebral blood flow here. Now, one could argue that these patients are maybe at the leftward end or the threshold of their autoregulatory curves, but likely there's just a slightly positive slope to that plateau. The other thing that we notice is that there's a widely variable limit to that lower autoregulatory threshold. And although people typically talk about this being approximately 50 millimeters of mercury, there's a wide variability in that lower end of the autoregulatory threshold. In fact, Dr. Hogan and his colleagues at Hopkins did a very, very nice study using cerebral oximetry to define what the mean arterial pressure was at the lower limit of autoregulation. And what you can see from this graph is that there is a huge variability from patient to patient in terms of where they start falling off that autoregulatory curve. Some patients are fine up down to 50 or lower millimeters of mercury. Others need to have their mean arterial pressures substantially higher. And I think we often fail to recognize that there is a wide variability in this. What are some of the parameters that have typically been thought to influence autoregulation? Pre-existing hypertension, diabetes, previous stroke, cerebral vascular disease. In fact, in this particular study, none of those clinical parameters could predict a lower limit of autoregulation more than the online measurement of autoregulation using cerebral oximetry. Well, we talked about increasing the partial pressure of oxygen during bypass, before and after, be it for air emboli or for other means. So let me talk about the influence of oxygen on cerebral blood flow. Well, we know that under normal circumstances, there's actually very little influence of cerebral blood flow with the normal partial pressures of oxygen that we see during normal life. Now, obviously, when we're very hypoxic, we have this compensatory increase in cerebral blood flow. So the PO2 per se doesn't have a great influence on blood flow unless you're very hypoxic. But from a cerebral oximetry perspective, we do know that the cerebral oxygen saturation can actually go up dramatically with increases in the partial pressure of oxygen. So if you have a partial pressure of oxygen of 150 or 200 millimeters of mercury on pump, and the perfusers are saying that's plenty, going to 400, going to 500 or more, you can actually have some significant increases in the cerebral saturation. So not a flow-dependent increase, but an increase in saturation nonetheless. Optimizing the CO2. Well, we know that there's a very distinct linear relationship between the partial pressure of carbon dioxide and cerebral blood flow. And in fact, for every millimeter increase in mercury of carbon dioxide, we have a 1 to 2 mils per 100 grams of brain blood flow increasing. So this is a very important point, and I think it's sometimes under-recognized how we manage some of these patients. So if you're going to consider that the normal cerebral blood flow is around 50 mils per 100 grams of tissue per minute in the normal capnic patient, I would be the first to admit that there are patients of mine that have been managed with hypocarbia. And hypocapnia, I think, is incredibly common in the perioperative setting. I don't know why that is. I don't know why our default has always been to hyperventilate these patients, but even minor degrees of hypocapnia, I would say, are very, very common. And if you look at what those relationships are, you can really be decreasing cerebral blood flow by 15 to 20%, even in these relatively, in quotations, normal end-tidal CO2s and partial pressures of carbon dioxide. And I would caution you against that inadvertent hyperventilation and hypocapnia. So certainly, I think avoiding hypocapnia is very, very important. But I think the other piece of this that we see when people are using cerebral oximetry to manage their patients is they say, well, if hypocapnia is bad and CO2 can really have a significant vasoreactivity within the brain, then I'm just going to make this patient hypercarbic. And I really warn you against that as well, because we also know that from the cerebral oximetry that if you give too much CO2 to these patients, you're going to be increasing the amount of cerebral emboli going to these patients by making their brain blood flow higher than it's needed for cerebral metabolism. So certainly avoid hypocarbia, but certainly avoid hypercarbia as well. Go out on the hemoglobin and the transfusion front. I'm not going to go into this in great detail. Suffice it to say that when you look at the regional oxygen saturation in the brain, there is a relationship between the hemoglobin concentrations at transfusion. So there is an impact there as well. Andre very nicely showed what the importance of cardiac output is. And I think this is, again, just to reemphasize a point that he made, is that I think we often underestimate just how important that is. And for years and years, I've been using cerebral oximetry, and I think underestimating just how much pump blood flow, as well as the pre-op and post-operative cardiac output can have an impact on these patients. And clearly, these are two very, very different patients that can have and this patient's going to have a much lower cerebral saturation. Lastly, in this algorithm, we talk about means to reduce cerebral metabolism. Obviously, hypothermia is used intermittently during cardiac surgery, and there are anesthetic agents that one can administer as well. So then to optimize cerebral saturation, we're going to look at our head position, our cannula, our mean arterial pressure, carbon dioxide, the partial pressure of oxygen, hematocrit, cardiac output's important, and the cerebral metabolism is important as well. So I think cerebral oximetry, which we've heard a lot about already at this meeting, I think is a very important surrogate for cerebral perfusion. It has some limitations, but if you can understand that for the most part cerebral metabolism is fairly unchanged, then I think it becomes a very good surrogate for cerebral blood flow. And I think optimizing and I think really individualizing that patient blood pressure, carbon dioxide, and oxygen levels is critically important to the optimal management of these patients during cardiac surgery. So I'll finish there, and I look forward to the discussion that follows. Thanks so much.